My name is Nitin Jain. I'm from the Department of Leukemia at Eminence Cancer Center in Houston. I treat patients with acute leukemia and chronic leukemias with focus on ALL and CLL. And I'm also director of the CAR-T program for leukemia group. And my research focus is on developing clinical trials for patients with CLL and ALL, including CAR-T cell therapy. So CAR-T cell therapy is a revolutionary technique. CAR-T cell therapy stands for chimeric antigen receptor T cell therapy. It's a therapy which was developed initially in the preclinical models in the lab, and the first CAR-T therapy was approved in the United States in 2017. And now CAR-T cell therapies are approved all over the world, including in India as of a couple of years ago. So the most common antigen for CAR-T cell therapy is what is called CD19. So it is expressed on the cancer cells. And what traditional CAR-T cells involves is that you take the cells from the patient. So it's like giving blood away for the patient. You take the blood out, you re-engineer these cells in the lab, which can take few weeks, and then you give these cells back to the patient after giving them some chemotherapy, typically is fludarabine and cyclophosphamide given for a few days, and then the cells are given to the patient, and then you monitor the patients for toxicities. There are two toxicities which are very important. One is called cytokine release syndrome, other is called neurotoxicity, or ICANS is the short form. And then typically around day 30 or day 28, you do a bone marrow biopsy or a PET scan, depending on the disease you are talking about, to assess for response. And then subsequently you do more assessments as well. So this is the general schema of CAR-T cell therapy, but it really depends on how the genetic vector, the gene which is inserted into the T cell. So depending on the size of the gene, the structure of the gene, the target of the gene, the efficacy, the toxicity can be very, very different. So if you're going to use a CAR-T cell therapy, you cannot just use one statement for the toxicity or one statement for the efficacy. It really depends on the disease, the vector you're using, the actual construct you're using, the patient population and whatnot. So if you're going to use CAR-T cell therapy in your practice, you should know the data about that particular CAR-T cell therapy, what is available, what is publicly known about the toxicity and safety and efficacy before you offer that to your patient. So in the context of ALL, and I'm going to focus on adult ALL, because pediatric ALL, and I don't do pediatric ALL, and pediatric ALL is slightly different. But in the adult ALL, currently any relapsed refractory ALL patient, I would say, is eligible for CAR-T cell therapy. Approval in the United States basically says relapsed refractory ALL. It does not say how many times they must have relapsed or refractory. So technically you can use it in the second line setting as well, meaning that first relapse you can do CAR-T cell therapy. And the data with CAR-T cell therapy does suggest that, again, we don't have head-to-head trials, but it may be better than blinatumomab and inotuzumab, which are the current approved therapies for relapsed refractory ALL. So at least what I think of right now, any relapsed refractory ALL would be a candidate, an appropriate candidate. But I do think that over time, there will be patients who will be less heavily pretreated. Maybe patients who are just in the first line setting. We could use them as consolidation therapy as part of a clinical trial right now, but I can see a future where we will be using CAR-T cell therapy in much earlier lines of therapy for patients with the ALL. So one of the most important factors, I think, is the tumor burden, as assessed by blast count, bone marrow blast count. So we know, and again, this is a general statement I'm making, for most of the CAR-T cell therapy, if you have 50, 70, 80% bone marrow blast count, those patients are not going to respond very well. They may have more toxicities as well. So generally thinking is less tumor burden, better. How less the tumor burden should be? Is it 5% blast, 10% blast, less than 5% blast? Should it be flow positive or flow negative? That remains to be determined. But the tumor burden plays a major role. Less tumor burden, patients are more likely going to respond. Other than that, there are some other factors which are a bit dependent on the trial. Some trials have shown that prior use of blinatumomab may have a negative consequence. Some trials have shown prior use of inotuzumab may have a negative consequence. Number of prior lines of therapy seem to matter as well. If you give a CAR-T cell therapy in patients who have 5 prior lines of therapy, they generally are going to do not as well compared to a patient who gets CAR-T cell therapy, let's suppose in second or third line of therapy. So those are the few, I guess, important factors which can affect the efficacy of CAR-T cell therapy. Yeah, so in terms of the diagnosis, so there are standard ASTCT consensus criteria which are well established, were published several years ago, which practically all CAR T trials uses these days. And those are well established, and you can grade the CAR T cell toxicity for CRS and neurotoxicity by that criteria. Now, how do you manage that? It really kind of, in some sense, depends on the construct you're using. But in general, if you have a cytokine release syndrome, the first line of defense is generally first is using just like paracetamol or something for fevers. But if it's a more severe toxicity, use tocilizumab. More severe toxicity, use those steroids. And there are other measures you can use as well. For neurotoxicity, tocilizumab has no role. The first line of defense is really the steroids. And the dose of steroids can go up depending on the toxicity. Also important will be seizure prophylaxis. Patients need to get an MRI of the head as well, maybe an LP, EEG, things like that. So those are management for toxicities, which again can be somewhat dependent on the construct you're using, but those are the general guidelines for management of those patients. So comparing transplant and CAR T cell therapy, in some sense, there are two different modalities. Transplant is just something you use when a patient is in remission. You don't transplant a person who has a 50% blast in the bone marrow or 10% blast in the bone marrow. On the flip side, CAR T cell therapy is a strategy to get someone in remission, right? You do someone for active disease. So CAR T is something you do for active disease patient. Transplant is something you do for patient in remission. So many times that argument, I guess, doesn't really apply in my mind. If a patient has active disease, you cannot do transplant. You need to get them in remission, and CAR T cell therapy would be an appropriate strategy to get them in remission. Question becomes then, do you need to transplant post CAR T cell therapy, and which is a debatable question. Some data suggest you may, some data suggest you do not need to. And I think MRD, especially if you have access to next generation sequencing MRD assays, which are very, very sensitive, can help make that decision. If you're NGS MRD positive, I would be favoring transplant after the CAR T. If you're NGS MRD negative, maybe you can avoid transplant after the CAR T. On the flip side, I would say if a patient is in remission, I think the standard right now, unless we know more, and a patient is a transplant candidate, I think we should go to transplant because that's a time-tested approach that in relapsed ALL, if the patient hasn't had a prior transplant, you're able to get them in MRD negative remission, you should proceed with transplant at that time. So I think we are going to see CAR T cell therapy in the next 5 to 10 years coming in early lines of therapy, second line therapy, even first line therapy for high-risk patients. CAR T cell therapy is a consolidation therapy where you're using it, patient is in remission, but you're using it to enhance the depth of the remission. CAR T cell therapy in less tumor burden patients, we may stop doing CAR T cell therapy or possibly in patients who have 50, 70, 80% blast and do CAR T cell therapy in low tumor burden setting. Also, I think we will see more dual or triple CAR Ts constructs, 1922, 1922-20, multiple CAR T targets together, and I think that may be a way to hopefully enhance the efficacy of the CAR T, but that remains to be proven, but again, trials are happening in this regard. Now, this is a wonderful initiative. I really like to thank the Apollo Cancer Conclave Committee for inviting me to give a talk on CAR T cell therapy. I really enjoyed the meeting so far, lots of good interaction, learning, and I hope to participate in future iterations of the meeting.